This is a very brief overview of the combined modality treatment for carcinoma stomach. So, carcinoma stomach management is divided globally based on geography, whereas in the West, people usually follow surgery followed by adjuvant chemoradiation. In the Europe, it's peri-op chemo with surgery, and in East Asia, Japan and Korea, it's surgery followed by adjuvant chemo. And we have evidence to support all of these. Surgery was inferior to perioperative chemotherapy in MAGIC and FLOT. Surgery was inferior to surgery with adjuvant chemoradiation in the US Intergroup 116 trial and the CalGB trials. And surgery was inferior to surgery with adjuvant chemotherapy in the ACTS-GC performed in Japan. But the problem is, in all these trials, all these bimodality or combined modality treatments were compared with surgery alone, and head-to-head comparisons between these combined modality treatments are ongoing and are available only in the abstract forms. That said, upfront surgery followed by adjuvant therapy remains an accepted alternative. So, if for some reason a patient had undergone a curative resection for carcinoma stomach, if the patient had undergone an adequate surgery, which means an R0 resection and a D2 lymphadenectomy with at least retrieval of 16 lymph nodes, and the final histopathology says PT2N0, the patient can be observed without any adjuvant therapy. If the patient had undergone an adequate surgery, that is an R0 resection with a D2 lymphadenectomy, and the pathology report says a P2N0 with some high risk features such as LVI, PNI, or high grade, an individualized MDT based discussion can be held and decisions can be taken. Anything upstage of PT2N0, that is either PT3 or T4 or N1, or an inadequate surgery if the patient had undergone a D1 lymphadenectomy or a D0 lymphadenectomy in the emergency setting, adjuvant is mandatory. In that setting, if the patient had undergone an adequate surgery and we were to give adjuvant for the high risk features, then we choose chemotherapy alone. Whereas if the patient had undergone an inadequate surgery, then we choose adjuvant chemoradiation. So, in this regard, adjuvant radiation can be regarded as something that is an alternative to the radicality of the surgery that we do. In other words, it is it is another method of local control that you are trying to achieve. So, first coming to perioperative chemotherapy, there are just three trials that we need to know: MAGIC, the ACCORD 7 FFCD 9703, and the FLOT trial. In the MAGIC trial, that is the MRC adjuvant gastric infusional chemotherapy trial, gastric and GE junction tumors and even some 10% of distal esophageal tumors were included. All of them are adenocarcinomas. One side, patients were randomized to 3 cycles of ECF followed by surgery followed by 3 cycles of ECF. On the other side, it was surgery alone. Only 42% of patients completed the post-operative treatment cycles. Despite that, the 5-year overall survival was 36% in the arm which had perioperative chemotherapy, versus it was only 23% in the arm which underwent surgery alone, proving perioperative chemotherapy is superior to surgery. Very similar results were obtained in the FFCD 9703 trial. An additional conclusion that was found was a doublet chemotherapy excluding epirubicin will suffice, and epirubicin was further dropped. Then came the most important FLOT trial, which was a phase 3 RCT, where gastric and GE junction adenocarcinomas, which were T3, T4, or node positive, were randomized between two perioperative chemotherapy regimens. One was 4 cycles of FLOT before and after surgery, and the other was 3 cycles of ECF before and after surgery, which is the arm which was used in the MAGIC trial. The pathological complete response rates were significantly higher in the FLOT arm. R0 resection was higher in the FLOT arm. At a median follow-up of 43 months, there was a significant DFS benefit seen in the FLOT arm, and the overall survival was 50 months in the FLOT arm versus it was 35 months in the ECF arm. The 3-year survival was also significantly higher in the FLOT arm. So this FLOT became the standard of care for perioperative chemotherapy in carcinoma stomach. So in the East, people do not receive perioperative chemotherapy. Rather, they undergo an upfront curative surgery followed by adjuvant chemotherapy because the evidence that came from the East supports that. So one was the classic study in which patients underwent a D2 lymphadenectomy followed by 8 cycles of Capox on one arm versus observation on the other arm. And obviously, the patients who received Capox had a superior 5-year overall survival. It was significantly higher, it was at 78%. So, one point to note here is that in this trial, even those patients who underwent observation after a D2 lymphadenectomy had a 69% 5-year overall survival, which is quite high compared to the Western literature and the European literature. The second was the ACTS GC trial, again in Japan, where patients were randomized after a D2 surgery to 1 year of S1 chemotherapy on one side and placebo on the other side. Again, the 5-year overall survival was 72% with adjuvant S1, where 60% with placebo, that is equivalent to observation. So again, to note, a 5-year overall survival of 60% with just D2 surgery and nothing else, no other modality treatment. It's quite high. It's seen only in these trials from Japan and the East. It is not seen in the European or the Western literature trials. So it is difficult to incorporate this practice anywhere outside Japan, where S1 is not available, and also D2 lymphadenectomy may not be guaranteed in many centers outside these Eastern centers. So as of now, upfront surgery followed by adjuvant chemotherapy can be considered standard of care only in the Asian population who undergo a D2 surgery. So on one side, we saw that perioperative chemotherapy is better than surgery alone in MAGIC, FFCD, and FLOT. And the other side, we saw adjuvant chemo is better than surgery alone in classic and ACTC. So between these two, which is the better approach? So that is being evaluated in the Prodigy trial from Korea. Again, stage 2A to 3C gastric or G junction adenocarcinomas were randomized to perioperative chemo, basically something similar to a FLOT, versus an upfront D2 surgery followed by 48 weeks of S1. The preliminary results show that the 3-year PFS was slightly better in the arm undergoing perioperative chemotherapy. There was no overall survival benefit, and the arm in which there was perioperative chemotherapy, many patients had a pathological node negative state. In the arm which underwent an upfront surgery, the final histopathology PN0 was only 22%, whereas in the arm which underwent perioperative chemotherapy, so the YPN0 was about 55%. Long term data is yet to mature. Now, is there a role for radiation in carcinoma stomach? So, the first uh, trial evaluating this came from the US, the Intergroup 116 trial. They did surgery, they evaluated the role of adjuvant 5-fluorouracil based radiation after surgery. But of note, only 10% of the trial population underwent a D2 dissection, 36% underwent a D1 lymphadenectomy, and 54% underwent a D0 dissection, which is not the standard of care at all. So it can be considered a very inferior surgery. So in this trial, the RFS and OS were improved with CTRT. So as we saw in the first slide, so when a patient undergoes an inadequate surgery, radiation can be considered an alternative method of achieving local control. So that is one of the thought processes behind this trial. So even though this trial cannot be implemented to the general practice where D0 or D1 lymphadenectomy is not the standard of care and D2 lymphadenectomy has to be the aim, in patients who undergo a suboptimal upfront surgery, in an inadequate surgery, see, chemoradiation can be considered as an alternative method of local control because it is proved to improve RFS and OS compared to surgery alone in this trial population. So, after a D2 lymphadenectomy, after a properly performed and adequate surgery, Is there a role for adjuvant chemoradiation? There are two trials from Japan that are evaluating this. One was the Artist 1 trial, where upfront D2 lymphadenectomy followed by two arms. One was chemotherapy alone, the other was chemoradiation. And there was no difference in DFS or OS, but on a subgroup analysis, chemoradiation was beneficial for node positive patients. So in Artist 2, again from Korea, what they did was they performed a D2 D2 surgery followed by they had three arms, and they included only node positive patients who were found to have a benefit from adjuvant chemoradiation in the Artist 1 trial. And so these were node positive patients after a D2 lymphadenectomy upfront. They were divided into three arms: adjuvant S1 for 1 year, adjuvant SOX for 6 months, and adjuvant SOX plus S1 based RT. So there was no benefit of adding chemo radiation over and above chemotherapy after a D2 lymphadenectomy is what the world interprets of this trial. But it is very difficult. There are so many nuances, technical nuances, statistical nuances that need to be looked into while making this general statement. It is difficult to put this trial into context outside Korea, where S1 is not available, and also the statistical design of this trial was to evaluate the superiority of either SOX RT over S1 alone, and not to provide a benefit of radiation, to evaluate the benefit of radiation. So the trial was powered statistically for based on 226 DFS events, and only 178 DFS events uh, had happened when the trial was prematurely terminated. So for all these radiations, for all these nuances, this trial has to be interpreted with caution. Now, in a patient who undergoes perioperative chemotherapy, for example, a patient has undergone 3 cycles of ECX or a FLOT based perioperative neoadjuvant chemotherapy, following which a patient undergoes surgery. Now, in the adjuvant setting, will we use adjuvant chemoradiation for anyone? Is there a benefit of doing that? So, that was evaluated in the critics trial. Again, there was no benefit of adding chemoradiation over and above chemotherapy in patients who had received preoperative chemotherapy. Again, to be interpreted with a lot of caution. There were a lot of nuances. The After the neoadjuvant chemotherapy and surgery, so we have a patient with a HPR report, and this stratification of chemotherapy versus chemoradiation was not based on the pathology report. So they did not stratify outcomes according to the post-treatment pathological stage, and there were a few other statistical nuances. So this trial needs to be interpreted with caution again. Now, preoperative neoadjuvant chemoradiation has never been evaluated for CS stomach per se, but in the cross trial where G junction tumors were included as a part of the trial population, neoadjuvant chemoradiation did improve the overall survival, but gastric cancer not involving the G junction were not included in the trial population at all. The last two trials, that is the Neo Aegis, which is comparing cross regimen with the magic or the flawed regimen. So we know neoadjuvant chemoradiation is good for G junction tumors based on the cross protocol, cross trial, and we also know magic of flawed, the perioperative chemotherapy is equally good. So in neo-AGs, patients with GE junction tumors are evaluated on one side with cross and other side with, it's a head-to-head comparison between cross with magic of flawed. The preliminary report was presented at the 2021 ASCO meeting after a median follow-up of 25 months, and the pathological response rates and R0 resection rates were higher with chemoradiation, but the 3-year survival was similar. The Top Gear, the another trial that is ongoing, which is comparing the Magic protocol, 3 cycles of ECF surgery with 3 cycles of ECF, with some form of a neoadjuvant chemoradiation arm, 2 cycles of ECF with chemoradiation followed by surgery and adjuvant ECF. This is ongoing. So neoadjuvant chemoradiation cannot be considered a standard of care for CS stomach at the moment. So in short, if a patient with carcinoma stomach is treated with a single modality treatment of surgery alone, it's definitely an inferior oncological outcome. The 5 year survival is only 23%. If the patient is treated with a perioperative chemotherapy with either a MAGIC or a FLOT protocol, we achieve better outcomes than surgery alone, and we have level 1 evidence to do that, prove that. If the patient has undergone an upfront surgery for some reason, adjuvant chemotherapy is definitely proven to be beneficial in improving overall survival based on ACTS S1 and ACTS GC and classic trial. And in a patient who has undergone an inadequate surgery, that is less than a D2 lymphadenectomy or an R plus resection, we can consider adjuvant chemo radiation based on the intergroup 0116 trial.